Hi, everyone. We're going to get started. Today is our second live talk. We did one last week because a lot has been going on and there have been so many questions coming into myself and my colleagues. We thought it would be a good idea to do something more large scale so we're not constantly answering questions on a one-on-one basis. And this way we get to kind of review topics that are happening, things that are changing. We have some updates from last week, so we're going to get started. So last week we discussed the variant updates. We discussed whether the vaccine is working. We discussed infection-acquired immunity. You know, if you had COVID, do you need to get a vaccine? We discussed boosters just a little bit, and we discussed pregnancy because a new study had come out. This week, I'm going to slide over those slides because we have some new topics to discuss. However, we are going to take some live questions and answers. So if you have any questions on prior topics or anything else, feel free to ask in the chat on the right side. If you're joining us from Facebook Live, you can type your questions into the question box. We have Tommy Frankel, another nurse in our MS Initiative group, who's going to help keep an eye on questions that are coming in. We also have Nesha Torone, who will possibly be moderating as well and letting us know when there are questions. So we'll get started. Today, we're going to discuss monoclonal antibodies, which are very effective treatment for COVID if you have specific indications for that. We're going to discuss vaccine boosters because now they're recommended not just for immunocompromised people, but for everyone. We're again going to discuss if the vaccine is working because we see that so many people who are vaccinated are still catching COVID. So what does that mean? And then finally, we're going to discuss the actual vaccine and the questions most people have because there are new mandates coming in. More people are getting concerned because of the new cases. So some people who have not gotten vaccinated might be more interested right now. Who are we? So we're a nurse-led organization that's dedicated to providing health education, combating misinformation. We're a bunch of nurses, some physicians, some scientists. We have an EMT. We have a doula in our group. We have hosted lectures in people's homes and online and in large venues. And we try to meet people where they're at and help them make sense of all the data that is out there. So the first thing that we're always going to review is what is evidence? Because many people will say, well, here's an article and here's a book and here's an opinion piece. But if you look at this, what we call the pyramid of evidence, okay, at the very bottom are things that are not necessarily proven. It's people that have ideas, opinions, editorials, and anecdotes, and they might all be important, especially if it's an expert opinion, but we listen and then we see if there's anything better. And then each of these layers over here up until the very top where there's a randomized control trial, and if there's a systematic review or a meta-analysis, that's where you have to kind of not ignore the lower level evidence, but put it into context with much better randomized trials that have emerged since then. And we'll probably come back to this slide again soon. So just to review what the variants are, variants occur when people get infected. There's a lot of myths that say that variants occur from vaccinating people. That's not possible. There's no mechanism by which that can happen. Variants occur every time someone is infected and the Delta and the COVID virus multiplies and replicates. And in one of those replications, some things just kind of tweak a little bit and you have a new variant. Now, many variants are not worrisome, but then there are some that are called VOCs or variants of concern. And what that means is that it's more worrisome for some reason. Sometimes they're more dangerous. Sometimes they're much more virulent. So the Delta variant, which emerged in India, has become much more contagious. We're going to review that briefly, and we're going to discuss why that matters. I'm just checking our chat box over here. It seems like there's already some questions. Hold on a second. Give me 1 minute so I can just stay on top of everything. Okay, so here we go. If you look towards the left, which is the R and the 0, which we call R naught, that's the term we use to describe how infectious something is. So the regular COVID strain that infected everyone last year, one person that was sick likely gave it to 3 others in their vicinity, which is infectious, but not as bad as it could be. The Delta variant infects approximately 7 people in your vicinity. And it's not just 3 versus 7, because realize the 3 people that you possibly infected the first time around a year ago, then go on to infect an additional 3 each. So that becomes 3 times 3 times 3. But if you look at the Delta strain, where you possibly infected up to 7 people, you've got 7 people infected who then go on to infect another 7 people each or thereabouts. So that is why the Delta variant is causing the surge that we're watching. And that is why it is so much more infectious, so much more transmissible. And we'll talk soon about breakthrough rates. Okay, so we're going to talk about this briefly, but we can come back to it. We discussed this last time. I was talking about why Israel is having a surge, and many people say, well, if Israel has a pretty good vaccination rate, why are vaccinated people getting sick? And the reason that happens is because every vaccine has a failure rate, and especially when it comes to the Delta variant, the failure rate is much higher because the vaccine was created for a different strain. So the failure rate for the Delta variant is higher, and that means that it's approximately 10%. It's probably getting higher now, maybe closer between 10 and 20% of a failure rate. Now, if you vaccinate like almost 6 million people, a 10 to 20% failure rate is still going to be really, really high. The good news is that most of the people there are doing fine, even though they've become positive for the coronavirus. If you look at hospitalization rates, the people that are hospitalized who have been vaccinated are primarily the elderly, whose immune systems are not as robust and whose vaccines did not create such great immunity for, and immunocompromised people. So what this shows us is, number one, we really have to protect and cocoon these two populations, the elderly and the immunocompromised. But it also tells us that for the non-compromised person, the vaccine is still very effective at ensuring you don't get significantly sick. Give me 1 second. I'm just going to switch how my screen is. Okay, because I wasn't able to see my chat box and there's questions coming in. Okay, 1 second. So, okay, we're going to continue now. So I'm going to skip over the next few slides because these were from last week. But we can come back to that if anyone has any questions. All right, so we're going to discuss monoclonal antibodies. And for right now, I actually want to just bring in one of our guests. Let me just see where she is. She works for the COVID Plasma Initiative, which has been responsible for helping the From community get access to treatment options, which are the monoclonal antibodies, which are unbelievably effective, probably the only actually effective treatment for COVID, although there are some other ones. We have steroids, we have blood thinners, of course, oxygen, some other supportive therapies. But the thing that's really responsible for preventing severe COVID are the monoclonal antibodies. So I'm going to share my screen again. Welcome to Shoshana, who I believe is the director of, Shoshana, tell us what you're the director of.
Hi, everybody. Thanks for having me, Bleemy.
Yeah.
So I am director of communications for CPI, COVID Plasma Initiative. We started, I can just give you a tiny bit of background. CPI was started, COVID Plasma Initiative, as the name suggests, with plasma, when plasma first became something that was recognized. Morty Serrell, Chaim Meyer-Lebowitz, two amazing people who just jumped right in and made it happen. When monoclonal antibodies first became something that was available right after Trump had it, we pivoted very quickly and got on board with just facilitating the access to monoclonal antibodies. Because there was so much involvement and so much previous history with different organizations in the government, we were able to just realize that this was something we needed to get to as many people as quickly as possible. So what we did is,
Shoshana,
go ahead.
No, finish up, and then I want to get to the 2 points that we have to cover.
Just giving the very quick background is that what it entailed was basically the drugs had been shipped all across the United States, and many people did not even know that they existed, including the people within the hospital. People were just so overwhelmed and trying to just keep staff and keep people healthy and deal with the emergent that so many facilities hadn't even began using monoclonal antibodies. And we literally just sat down and spent hundreds of hours making phone calls and just creating a relationship with facilities, finding out what the criteria were, what was the system, where did you go, what did you need, and just we started a hotline. Chaim Dessler, Chad Vatumin, Zeldi Open is one of the directors, not just director of communications, but director of everything. Yael Miller, Tova Hershkowitz. I could sit here and like, there were so many amazing, incredible volunteers who jumped right in, donated hundreds of hours to set it up. We started a hotline. We started just word of mouth, some advertising, some just letting people know through WhatsApp and posts and things like that. This is here. Please call us for treatment. And we just spent literally, our ad still says 24/7. We're here to facilitate access to this treatment, and with incredible, Baruch Hashem, amazing results.
Okay, so just for the people on Facebook Live who probably don't hear what's happening on Zoom, unfortunately, I don't know if you can hear it through the microphones a little bit. We have Shoshana Bernstein from the COVID Plasma Initiative, which is not really working that much with plasma anymore, but they're facilitating monoclonal antibodies. So I just want to spend like 2-3 minutes on discussing who should consider being treated with monoclonal antibodies, because the indications have changed. There's a few more categories of people. And then I want to talk really briefly about possible side effects. I think there's this understanding or this misunderstanding that vaccines are bad, monoclonal antibodies are good, and many people don't realize they're both under the same emergency use authorization, but that still means they should both be used. Vaccines, of course, should be used, but in the event that someone is still sick, either vaccinated or unvaccinated, it still should be taken. But we still have to realize that it still is a new product and there are some side effects to be aware of. So go ahead, Shoshana. Can you tell us about the original population that should be treated, and let's focus on the criteria for them.
Absolutely.
And then let's quickly talk about,
Okay, so when monoclonal antibodies first started, there was a question of supply and access. So the criteria was set a little more restrictive, meaning that you had to be high risk. You had to have a high BMI, which means your weight and height was higher. So that qualified you. You had to be, over 65. You had to have certain conditions. And that was simply because they didn't know if they were going to run out, and they wanted to get it to the sickest people quickest. Now that we have more supply, the things that you have in front of you, I'm just taking a quick look, is basically it's become almost accessible to almost everybody, because one of the main things that they did is they lowered the BMI. And what's interesting is that some facilities, when you try and access their systems or you go online, this is so new that they haven't even updated some of their information. And lowering the BMI, what it meant was that the average person who's not extremely thin qualifies, because the qualifier is now a BMI of 25 and over, and most people are not, size 2.
right.
So a lot of people now qualify, and then there's pregnant women qualify, people who take certain medications qualify, and then in the most recent news about 2 weeks ago, I think it's going to be 2 weeks tomorrow, will be exactly 2 weeks, they announced prophylactic, which is preventative qualifiers. And that's really been and is going to continue to be a major game changer. So if you did not get vaccinated and you were exposed, you can now get monoclonal antibodies. And if you were vaccinated, but you are immunocompromised, which thousands of people in the United States are, whether it's a cancer patient, a transplant patient, a patient who's on an suppressive drug, there's all sorts of different drugs like that. They say, well, I was exposed, and you can walk in now to a growing number of facilities and you can get monoclonal antibody treatment.
Okay, and the easiest way to really find out, how to go or where to go is just to call your hotline.
So, yeah, well, that's also, I always say 24 hours in COVID time is like a week, because what's happened just in the last few days is Alabama, Texas, and Florida have announced masked sites for monoclonal antibody infusions. So they have the capability, each state is a little bit different, but they have 9 or 10 or 15 around the state. In fact, Texas announced this, I think it was Wednesday morning or Tuesday morning, and then Tuesday afternoon, their governor came down with COVID and went straight for monoclonal antibodies.
Right.
So it's really, they're just breaking this wide open. Florida was the first. Each state is a little bit different. CPI continues to facilitate access to treatment across the United States and even into other countries as well. So CPI's number, which is 8484 plasma. Did I say that right? I should know my number by heart. I'm going to double check it. I don't actually ever dial the number, but you can just pick up the phone. Our hotline is available 24/7, and we either know which facility is closest to you, or we will find which facility is closest to you.
Okay. Shoshana, what are the side effects people may or may not have?
Okay, so what we're seeing, and it's interesting because things do change from strain to strain. So what we saw 4 months ago, 5 months ago is not necessarily exactly the same that we're seeing now. What we've told people and what we've seen is 24 hours of possible headaches and nausea.
Okay.
There are, some very few cases of an allergic reaction, which we don't even know to be able to pinpoint for sure if it's an infusion reaction or monoclonal antibody infusion, but it's an allergic reaction that's treatable with Benadryl. So it's not something that, means a person is, God forbid, sick, but it is a reaction. We did see with the Delta that, and we don't know why, but it's very fast moving, this strain. So, people can be fine day 1 and then not fine on day 2 or 3, where with previous strain, took a little longer. And possibly because of that as well, we're finding that some people can get sicker post infusion before they get better. So whereas but we still have people who are, sending us WhatsApps and saying, oh my goodness, I'm like a different person, and it's the next day. Right. So, nausea and headaches were the 2 main symptoms. And, there is the possibility for allergic reaction, which is why in any facility you go to, they'll keep you for an hour post infusion to monitor, how you're reacting.
Yeah. Thank you so much, Shoshana. Was there anything else you wanted to quickly cover before we move on?
Yes. So first of all, I just want to make sure that I get the number right. It's 8284 plasma. Okay. And a couple of things. With Delta, we've gotten a lot of, I just have a cold, or I have a sinus infection. And we've been urging people, just test. We're so blessed in the United States to have such quick, easy, free access to testing. And especially there are adults. I mean, I don't know if you're going to talk about this, but I'll just say very quickly, if someone was not vaccinated and did not have COVID previously, it's almost impossible to think that if you leave your house, you won't get Delta. Yeah, that's what we're seeing. There is breakthrough through vaccinations, and like you explained and we'll explain further. And then there are some people, much fewer, but there are some people who are getting repeat COVID without having been vaccinated. So it's COVID, like it always is, defies every explanation sometimes, is all over the place. And we just urge people, I had a situation last week where a guy, his parents wanted him to treat and he didn't want to. And then I finally got him on the phone, and as he was telling me he's not going to go, he started coughing. I said, 5 hours ago you were fine, and now you're coughing. So we want people to understand a lot of what we get is, but I'm feeling fine. Right. And we're like, perfect. That's the perfect time to get monoclonal antibodies, because we have no way of knowing how low is your low going to be. Right. How sick is a person going to get? So just avoid getting sick altogether. That's number 1. And just, don't wait, test early, treat right away, reach out. A lot of people, we always tell people, we're not doctors, speak to your doctor. But some doctors have turned around and said, ask CPI, because we have access to the information, and we've been doing so much of this. So we're really here just to make sure that no one right now needs to get extremely sick or, God forbid, die from COVID, because the treatment is working. Yes. And we're here to give it.
Yeah. Okay, thank you so much, Shoshana. These are all really important points, because you do need to treat early. Once you get too sick, you're no longer eligible for the antibodies. And it's also really important to keep in mind if you're immunocompromised, or you have loved ones who are immunocompromised, and if you're pregnant. I had a question from a woman who had received both doses of the vaccine in her early pregnancy, but that was all several months ago. She wanted to know if she should get a booster. The recommendation is not to get a booster if you're pregnant, if you've already been vaccinated, but rather to get monoclonal antibodies if you're exposed to someone who's COVID positive. So these are all good questions that have been coming in. So I'm going to just take a minute to check our chat, see if we have any questions on this topic. If anyone would like to have any questions about monoclonal antibodies, I encourage you to ask that now because Shoshana is with us and can, hypothetically help us. So I'm just going to take a look over here. So let's see. Why aren't we talking about preventatives and early treatments that don't require a hospital bed and don't have these side effects? Well, monoclonal antibodies don't require a hospital bed.
Right.
So,
right. So I want to specify also that once a person is hospitalized, you no longer qualify for monoclonal antibodies. You've missed the boat, which is why because Delta is so fast moving, that's why we keep pushing the testing.
Yeah.
Like, just go test and find out, and then you don't have to get sick.
Yeah. Okay. So I'm going to move on because we have a couple other things, especially boosters, which is a hot topic. So I'm going to move on. If you stay on, Shoshana, if we get any questions, I'll direct it to you. But if you need a lot, that's fine.
Okay. I'm here in the meantime. Yep.
Perfect. Thank you so much. So for those of you who were joining on Facebook Live, we just had a quick review on monoclonal antibodies. And the important message is, number one, call as soon as you're positive to find out if you're eligible for antibodies. Number two, if you've been exposed and you're immunocompromised, call them because it can prevent you from getting sick. And number three, please test frequently and test often because you might not know if you're positive for COVID, you can be spreading it. We do have another question. What happened to the cold and the flu and the common cold? Well, that's actually really good news. We usually lose about 120 children or so to the flu every year. That's approximately the amount of children that die of the flu. This year, the number was 1. We lost 1 child to the flu, which was really great news. The answer is that the mitigation measures that were put into place for COVID were good enough to help reduce the flu, which is much less virulent than COVID. So they didn't work as well for COVID, although masks and social distancing prevent the spread to some degree, but not completely. And that's why we needed the vaccination program, which we're lucky to have so soon. But these measures did help significantly with the flu. So there were much lower rates of flu and 1 death instead of the usual 120 deaths of flu. So the reason they work for the flu and not for COVID is because the level of virulence. That's pretty simple. Just like some things work for airborne diseases or different droplet diseases. So they're not all perfect, but we are glad that there were lower rates of flu deaths. We're always happy when less people die. So I'm going to go back to my screen right now, and we're going to continue with our next topic, and then I'll pause for questions again. Okay. All right, so boosters, the $1 million questions, okay? So last week, there was a recommendation for immunocompromised people to get a booster shot, okay? Israel and Germany started this, now the United States got on board last week. So the reason for that is that people who got the vaccine on time, got 2 doses, and ended up, the efficacy rate for the COVID vaccine for immunocompromised people is somewhere between 40, 50, 60%. So not everyone mounts a full immune response after 2 doses of the vaccine, especially if they're immunocompromised. So the 3rd dose was recommended for that reason. So okay. All right, do you hear me now? Was I muted the entire time? Oh, just for a second. Okay, perfect. So let me just go back to my screen. I don't know what happened. 1 second. All right, so what they've realized is that the 3rd dose gives people who did not develop antibodies a higher chance at actually building immunity. So that was recommended for immunocompromised people. The FDA is still recommending that although people get the 3rd dose and it increases the likelihood that they'll have some immunity, they still need to be really careful around that population. Still need to be really careful around that population. And immunocompromised really also means the elderly, because the elderly people are still extremely high risk even though they're vaccinated. So 1 second, people were asking me questions all week. What does immunocompromised mean, right? Am I immunocompromised? What qualifies me? So if you're actively being treated for cancer, if you've had an if you've had an organ transplant and you're taking immunosuppressives, if you have like a severe immunodeficiency disorder, HIV, or this is the one that's more common for many people, especially in the frum community. If you have something like rheumatoid arthritis, spondylosis, any other rheumatic disease, if you have, let me see, colitis. Colitis is really common. If you're on either high dose steroids or a special agent like other biological agents, that is often considered immunosuppressive. And then therefore you are considered moderately to severely immunocompromised, and you absolutely should get a third dose. So I definitely recommend it for all of my patients. And I definitely think anyone that's immunocompromised, if you're unsure if you've had a good response to the first 2 shots, you should get your third shot. But then this week, this all kind of became moot because now everyone's recommended to get a booster. And I'm going to review a little bit about what we know about current immunity with the Delta variant and why it's now recommended for everyone. But I just want to give this like the corollary that this all may change because this is all really going on in it's all very rapid. Different countries are kind of having different findings right now. Israel is a little bit of an outlier. So I think it's just really important to listen to what we have going on right now, but then also realize that by next week, recommendations may change, data may change. So the CDC recommended that everyone who has been vaccinated should get a booster beginning 8 months after you got your second dose. The minimum time frame between your doses should be 28 days. So if you're at least 28 days, but preferably at least 8 months, well, at least 28 days, but also 8 months from your last dose, you can get your booster. Now, we know that the vaccine is working in the sense that even though it's not preventing infection at the rate it was with prior variants, what it is really effective at is preventing hospitalizations and deaths. And this data is being borne out in hospitals in every single country. The very, very, very large majority of hospitalized people are overwhelmingly unvaccinated. The people dying are overwhelmingly unvaccinated. So when we look at vaccination and if it's effective and why we develop vaccines, it's for 2 reasons. Number one, we want to reduce infection and transmission. Number 2, we want to reduce severe illness, death, and any other ongoing issues that people may have after severe illness. So some vaccines are effective at completely stopping transmission. Some vaccines are not. So the flu shot is a good example of that. Most people can, most people know that people will say, oh, I got the flu shot, got the flu anyway. This is actually how the flu shot works. Very similar to how we're seeing the COVID shot work for the Delta variant. What we see with the flu shot is that it doesn't necessarily always prevent the flu, but it does prevent severe illness with the flu for many people, and it reduces deaths in many people, primarily for children, primarily for the elderly who are at high risk for getting really sick with the flu. So this is the same thing for the Delta variant and the COVID vaccine. The COVID vaccine was developed for other strains, and it worked much better for other strains. But now we have a really different strain, a much more transmissible strain. And what we see is that while it's not necessarily preventing vaccinated people from getting sick, it's preventing them from dying. And to most people, that should really be a really strong case for getting vaccinated. Just to go back to the third dose that's recommended, the studies that have started rolling out and realize how new this is, so this may change, it may increase, it may decrease, but boosters are providing people with 2.5 times the protection against the Delta variant, as opposed to having the regular 2 doses. And they're probably going to start rolling out in September. Now, there's something I want to talk about over here. Second. So a lot of people are looking at this outcome and these new data and saying, oh, okay, it's all about money. People just want to keep giving us boosters. And, it's all about, Pfizer and the bottom, outcome. And people are getting jaded. Oh, I thought it would work. Oh, now I'm going to need a booster every 6 months. Is that what's going to happen? The answer is probably not. And I'm going to explain why that is. Most vaccines require a booster, but most boosters are given months separated, okay? So people who were vaccinated, and I'm gonna go with the mRNA vaccination since that's the primary mode of vaccination. In the United States, only 12 million people got the Johnson vaccine. So let's assume we're talking about Moderna and Pfizer. You got the 2 shots a month apart. That's not considered a first dose and a booster dose. That's considered your first 2 doses just separated, okay? The reason it was given that way was because you needed both doses to really develop full immunity at the time. And if you look at people who are fully vaccinated, which means 2 doses, versus not fully vaccinated, which means 1 dose, there's significant difference in their infection rates, in the disease severity. So what we know is that you needed those 2 doses initially. We gave them close together because we're in the middle of a pandemic and there wasn't really a whole lot of time to give you 1 dose first and wait 6 months. We had to get everyone their full dose of antibodies, get them immune fast. We got our first 2 doses. Now it's time for your booster. And pretty much everyone needs a booster. The only people who may not need a booster, and I should preface this by saying that this is pre-COVID, the only people who didn't need a booster may have been people who had COVID first, because your COVID infection is your first exposure. If you get 1 dose of the vaccine a few months after that, that's kind of your booster. And before the Delta variant came around, I personally was advising people to, if they've had COVID, 1 vaccine is enough. The data was supporting that. Prior COVID infection plus 1 dose of the mRNA vaccines really provided very superior immunity. And for people, especially people who had reactions to the first vaccine, or people who have immunodisorders, who maybe had a little flare after the vaccine, before Delta came around, I told them 1 vaccine after infection is enough. So what we know is 2 doses, whether it's an infection and 1 booster, or first dose, which is really a 2-shot first dose, as we've seen, and then a booster, is really what gives your immune response the right tools to battle infection. So most of the epidemiologists out there right now are not predicting that we're going to need, did I just color all over my screen? I don't know, I see like, sorry. Most epidemiologists right now are not anticipating that we'll need an additional booster after this one. This may change if we get other concerning variants that are causing new surges, or are causing increased rates of death or hospitalizations. If they recommend another booster at that time, it might be the best idea for that time. But right now, no one really anticipates it. What most people feel is the way out of this pandemic. And since this surge is happening, that's what's on so many people's minds. Like, I thought this was over. What is going to, the outcome of all of this is likely going to be that COVID will be around like the flu. But since it's much more dangerous than the flu, we're not complacent enough to sit back and say, let's just wait for everyone to get COVID. That's not acceptable. Too many people are sick, too many people are dying, especially the elderly, especially people who have other immune conditions. That's just not acceptable. The better way to let everyone get COVID, or at least be exposed to COVID, is through immunization. So whether it's through infection or immunization, once people have already been exposed to COVID, it becomes that much more safe to be exposed to future variants or other variants. And it may just be an endemic disease that we end up living with. We can't live with it yet, because we don't yet have full exposure to everyone on the planet. We still have people who have never had COVID and are not vaccinated, and we're watching what's happening with that. So I know I've spoken for a while on this, but I think this has been triggering a lot of hesitancy in a lot of people, and a lot of questions about the future. Are we going to have to keep boosters and all that? I also want to mention something. About 2 months ago, the FDA applied for authorization to allow a 3rd shot. And I'm sorry, Pfizer applied for FDA authorization to give, to authorize a 3rd dose. And guess what they were told? No, it wasn't needed. 2 or 3 months ago, before the Delta variant was becoming so prevalent, Pfizer, as the drug company, was trying to make a buck. I'm sure they were. They were trying to, get a 3rd shot approved and start advocating for that. But the gatekeepers, okay, the people in charge of deciding who gets vaccinated, that's not the pharmaceutical company. So those gatekeepers, I was really happy to see that they actually pushed back and said, no, the 2 doses are working really, really well for now. There's no 3rd dose necessary. Delta came and changed everything. And now we see that the recommendations are changing, which I'm just going to talk about that for 1 brief minute, because that's one of everyone's biggest complaints, and it's legitimate, it's understandable. Everything keeps changing. Why does nobody know anything? How do I trust that people know what they're talking about now? Why should I mask up if before we didn't have to, and before we did, and now we don't, and only here and not there? The answer is that we're watching science happen. And for most people, including myself, this is really the first time we're watching something new and something so dangerous take hold of the entire world. And what we're also watching is a huge collective of hundreds of thousands of professionals, whether they're immunologists or scientists or virologists or epidemiologists or nurses follow the data that's emerging, make sense of it, and keep tweaking that as things change. Okay, it's just really simple. It's like taste testing a recipe. The first time you're going to make something, you're going to have to keep changing it. And it's frustrating to people. I know that for the first year, I had a very easy time masking up whenever I went into a store. It wasn't a big deal. Now it's harder because after my vaccination, I stopped masking up for the most part, except for when I'm at work. It's much harder to take a step back. And I've been struggling with that, and many people have struggling with that. But it's not a good enough reason to throw all reason out and to say, well, never mind, they keep changing the recommendations, so I no longer trust anything. So this is like the crux on the booster information that I really wanted to get out because so many people had questions about that. Let's see if there was anything else we were going to discuss. Okay, so this I discussed last week. I'm so sorry. I don't know if everyone can see that red stripe across my screen. I must have colored and I don't know how to undo it. So you'll have to look at it with me. But we discussed this last week, so I don't really want to review it again unless it's necessary. But we reviewed how vaccines work, not just to prevent the disease, but also to mitigate it if you're going to catch it. This is important. The last two to three bullet points is that only 2 to 4 out of 10 vaccinated people are catching COVID. And this number is kind of changing. Israel is seeing much lower efficacy, so I'm watching that. But other countries, including England and Europe and Scotland, the United States, we're not seeing a 40% efficacy. We're seeing closer to 70, 80% efficacy. So we have to wait around and see like which numbers end up really winning this war because different countries are not in agreement. But realize that if you're unvaccinated and never had COVID, your likelihood of catching COVID, especially during the surge, is exceptionally high and much higher than it's probably been for a while. And again, this is a little different for recovered people because you do have a certain degree of immunity. Just switch my slide. So this is a chart of several states, their amount of people that are positive for COVID and the fraction of them that are fully vaccinated. So the orange stripes on the right side are the non-vaccinated people who are COVID positive, and the tiny little green fractions on the middle column here are the people who are fully vaccinated. Much smaller percentages of people are vaccinated. So even though we know a lot of people who are COVID positive, I have friends who are vaccinated who are COVID positive. I'm trying to stay negative. I have cancer patients and I live with my grandmother. So I'm a little anxious again during these times because I know I can catch it. It's still much more likely if you're unvaccinated. So does it work against Delta? We've discussed this. This is just some data I found out of San Francisco. As of, I think, a week ago or 2 weeks ago, they had 3,000 patients with COVID in the hospital. Out of those 3,000 patients, 16 of them were fully vaccinated. So again, the very vast majority are completely unvaccinated and they're getting much more severely ill. And okay, now we're going to talk about hospitalizations and death. Again, we reviewed this last week, but we can review that over here really quick, and then we'll try to go to some questions. But what I'm highlighting over here, out of 164 million fully vaccinated people in the United States, there were 7,000 hospitalizations and 1,500 deaths out of the 164 million vaccinated people. This is a fraction of people who are truly getting very sick and who are dying. And most importantly, or not really most importantly, but it is an important takeaway that 75% of these people were elderly and 40% of these people were immunocompromised, which means you need to get your boosters, those two populations, and those populations need to really be more properly cocooned. So everyone around them really should be vaccinated and just being really careful. So because many people are now concerned, newly concerned, I've been getting a lot of messages from people saying, well, I never got COVID. I thought I was immune. I thought I would never get it, or I had COVID already. Do you think I should get vaccinated? I thought it'd be a good idea to kind of go back in time and review the questions that many people have had over the last several months and see if anyone has any questions we can address tonight that might help you make a decision for yourself. I'm just going to go out of presentation mode so I can see the chat box. All right. Okay, you can ask questions through Facebook Live or on the Zoom chat box. 1 second. Some of your questions are not very clear to me. So if you have a question, maybe rephrase it. There's some questions about prior infection. If you can please rephrase your questions, those of you, please do so I can answer you. So someone said, why are we ignoring the survivors and long-term wide spectrum immunity? I'm not sure what you mean by why are we ignoring survivors? Why are we aggressively pushing the vaccine on people who are on people who are not high risk? Well, because we try to protect the high risk. Okay, there are about 7 million people in the United States that have immunocompromised disorders. You never know who can be immunocompromised. You don't know if it's someone you work with. It might be a child in your child's class. So the entire concept of public health is that when something is infectious, it's public. So the decision to vaccinate is very different than most medical decisions that are really just about you and discussing it with your doctor. This is a little bit different. So the reason we advocate for vaccination for everyone is to protect everyone. As far as long-term immunity, I actually wrote a paper and I submitted it for publication 2 weeks ago. And as I and the other co-author were waiting to see if it got published anywhere, we realized it was probably not a great idea to publish it. So I said, you know what, let's wait. I think it'll be rejected anyway. And it was rejected from 3 different publication sites. And I was very happy, and I'll tell you why. The paper we wrote argued that the vaccine passport should have an option for prior infection. We wrote that based on the data and based on steps taken in Israel, Europe, Switzerland, you can get a vaccine passport, which allows you access to restaurants and the gym and venues and whatever it was, based on either being fully vaccinated or having prior infection. But you only get a 6-month allowance for that. After 6 months, if you've been prior infected, your passport's no longer valid, but you do get 6 months out of that. And I wrote a paper with a colleague and we advocated for that because the data is so robust, or rather it was before the Delta variant came out. Most people who had had COVID really were not getting infected again. So at that time, or rather we wrote this paper 3-4 weeks ago, we sent it in and it was rejected. And I was very happy because it no longer really aligned with the data because things had changed so rapidly and we see that people are getting infected again. Okay, I'm just gonna take a look at some other questions. We have a question from Facebook, 1 second. Do I support lockdowns? Well, we haven't really had that many lockdowns. A lockdown means you're not allowed to leave your home, you have to shelter in place. New York City had that for about a month during the surge. I definitely agreed with it. I mean, people were dying, they were legit dying, and our hospitals did not have beds anymore. So, I mean, there was really no other way to handle that 1 month. We had to contain it. I don't really think we've had many lockdowns. Some cities might have had some stricter rules on and off. I mean, I support strict rules if there's a terrible surge and people are dying, then yeah, sure. J&J, 1 second. J&J saying that their vaccine efficacy doesn't wear off. That is not true. Let's talk about J&J. Most people didn't get J&J, so not everyone has this question. My husband got the Johnson vaccine actually. So this is something I do pay close attention to. Okay, so this really large study came out of South Africa that tracked the Johnson & Johnson vaccine that was given to about, I think, 3,000 healthcare workers. Now, what's interesting is that you're tracking healthcare workers who are exposed to COVID all day, every day, but you're also tracking them and they're probably wearing good PPE. So it's hard to guess, are they at higher risk for catching COVID because they're in hospitals, or are they at lower risk because they hopefully have PPE? So you need to keep that in mind. They found that it's still 70% effective with the Delta variant. So it did wear off a little bit. Other countries are recommending 1 mRNA booster after a Johnson & Johnson vaccine. And San Francisco is doing that. San Francisco is offering a an mRNA vaccine, just one dose of an mRNA, doesn't matter which one, if it's Moderna or Pfizer. So I'm not gonna recommend something that's not necessarily FDA approved or recommended by the CDC. I'm just telling you what people are doing to keep safe. Let's see. What is the percentage of people being reinfected? That is a good question. I'm gonna guess it's much lower than people who are vaccinated, but higher than people being vaccinated, but significantly lower than for people who are, Shoshana, can you unmute yourself or do I have to unmute you? Nah, you're all muted. You're all muted. I have to find you. Hang on a second. Shoshana has something helpful to say. Wait a minute. Oh, there's a lot of people in here. I have to find you.
The Bernsteins.
Oh, there you are. You're talking.
Oh, okay. Hi. So I can share with you, and it's, again, this is not like hardcore statistical data gathered by statistical data gatherers, but we had some different people weigh in, and what we've started doing is when CPI takes calls, we compile our own data. So we ask all the questions. Did you have COVID before?
Right.
How long ago? Did you have vaccines? What the numbers that came out to us, and it's, again, we do have some sort of count, is about 80%, and this is Delta, this is recent in the past month, 80% did not have COVID previously and were not vaccinated.
Oh, okay.
Okay. And then we had about 13% that were breakthrough.
Okay.
Meaning, okay. And then 7%, which was VP.
Okay.
So that was
helpful. It kind of makes sense. It correlates with the data and with what we're seeing. And just for the Facebook people, what Shoshana is telling us from the data from people who are calling in with monoclonal antibodies is that most of the people are unvaccinated without prior COVID, right? It's funny because we think of the frum community as like everyone had it, but not everyone had it. Many people never did. So most of the people getting sick now were never vaccinated and never had infection. 13% are vaccinated and are having a breakthrough. And I'm sorry, what was the last one?
About 7%.
Oh, the remainder. And about 7% were vaccinated. Were
previous COVID did not get vaccinated, which is just what
no vaccine.
Which is exactly what you talked about, where that was holding people prior to Delta, but it's not really holding them as well anymore. Especially, and I can't stress this enough, in the 20-year-olds, that younger age, who opted, had different concerns, didn't vaccinate. We're seeing a lot of that age. So
okay, thanks, Shoshana.
Okay.
Okay, so there's a couple more questions coming through. So this is a really good one. I'm not going to spend a lot of time on it. I don't have slides on it. I can add it to my lecture if we do another one of these COVID lives next week. Is there a valid concern for fertility? The short answer is no. Okay, and I'll tell you what the data says. Studies out of Israel have looked at what they call ovarian reserve, which means tracking hormone levels in women, looking at their hormonal levels, right? Ovulation, pre-ovulation, post-ovulation. And they have found absolutely no difference in women who were vaccinated compared to women who were not vaccinated. Their ovarian reserve is completely fine, okay? Their ability to develop follicles and, get pregnant was not impacted. Other studies looked at IVF outcomes, okay? In vitro fertilization, which is so highly specific, so expensive. You want to really give it your best shot, literally. IVF outcomes among couples who were vaccinated, who were not vaccinated, were compared. Outcomes were the exact same. So here's what we know. We know that there's a fear that it can affect fertility. What we also know is that there's absolutely no basis for it. So if at some point a study comes out and shows that there is a correlation, then of course we have to talk about it very seriously, because that's a very serious side effect. Okay, we don't want to vaccinate people against the disease only to give them a long-term effect like that. Unfortunately, this is one of those things that's a rumor, has not been borne out in the data, and has not been even anecdotally borne out. So I hope that answers your question somewhat. If I had COVID 10 months ago, do I need to vaccinate? I really do think you do need to vaccinate, because the outcomes right now among unvaccinated people, even if they had COVID, are still not as great. Right now, I would not recommend not vaccinating. Even several months ago, my recommendation would have been to get at least one shot, because your COVID exposure is kind of your exposure, and your next dose would be your booster dose, which really provides that superior immunity. So I definitely think that you need to get vaccinated. Let me just scroll down over here a little bit. We covered the J&J, fertility. It doesn't make sense that you can get a vaccine and still get sick and spread it. That's actually how many vaccines do sometimes work, okay? It reduces your likelihood by 70% or 80%. 7 out of 10 is still a pretty good chance of not getting sick. If only it would be more perfect and there wouldn't have become, this new strain, it would have been near perfect, as we've seen for, from like December until June, it was working very well. Unfortunately, the new strain makes it a little less effective. I don't think it's a great way to look at this as a 0 or 100. Okay. Even 7 out of 10 chances of not getting sick and not spreading it is still better than, 100% chance of getting sick. So if I never had COVID and I was vaccinated in December, January, should I get my booster now? Do I have to wait until September? You don't have to wait until September. I think you can get it sooner. I know that from I'm not going to say ethical standpoint, but there were a lot of opinions from the medical community and from the public health community as to whether we should recommend boosters. And that's because many parts of the world haven't yet received their first or second vaccines because of shortages. That being said, I don't believe the United States is really giving their vaccines to other countries. If they're not actually going to give their vaccines to other countries, then we're helping the effort by boostering ourselves and still reducing additional variants from producing and helping our country at least have fewer illnesses and deaths. So the timing of when they're recommending it may be a little bit impacted by when the boosters will become available over here and all that. But theoretically, you can go into any pharmacy that has it. If you were vaccinated December, January, you can definitely get your booster. I was vaccinated December, January, or actually no, January, February. I'm ready for my booster. So, I'm happy to get it soon. I have a question from someone. Are you a doctor? No, I'm a nurse practitioner with my doctorate in clinical practice. And I'm also a professor and I teach research to doctoral nursing students. So that often that kind of training has helped me a lot in understanding research and data analysis. Does the answer change if you had severe COVID? So this is from the person asking if he had severe COVID a few months ago, should he get the vaccine? The answer I would say is still yes. You might be less likely to get sick again if you had severe COVID, although the data has shown that antibody levels and severity of COVID is not necessarily reflective of how much immunity you have. Sorry, I have these timers going off. So I would still recommend you get the vaccine. Okay, so someone said, hi, believe me, I'm high risk. I'm a cancer patient and I have young children. We depend on others to get vaccinated. Yeah, and this is why we talk about this all the time. It's very hard for people who are perfectly healthy and whose loved ones are perfectly healthy to realize how many people around us are really scared. Shoshana, I didn't unmute you before. I think you were able to do it. Wait, I see you here. Okay, go ahead.
I wanted to mention that one of the things that has been happening with the prophylactic is we're trying to get this information to oncologists and to transplant teams. This woman who's a cancer patient may be a candidate for prophylactic antibodies. Mm-hmm. In fact, I was Mayo Clinic is a parent.
Let me just interrupt you. Even if she doesn't know she's been exposed?
So that's a good question. And there's different variations of the interpretation of the language from mm-hmm. the emergency use authorization from the FDA. But I can tell you that I was told the Mayo Clinic is giving prophylactic antibodies to all immunocompromised patients who leave their homes. Because with Delta right now, if you're going to the store, you've been exposed.
Right, that's a very good point. And just a side point, I know that many people have probably heard about the about the myocarditis risk in young men who get the vaccine. It's a very, very, very low risk. But many people who have young adult boys, teenagers or young adults are saying, I don't know, they're so young. If they get COVID, they'll probably be fine. Why should I expose them to a vaccine that may cause myocarditis? Realize they probably won't cause it. It's extremely rare. And all the people who had myocarditis are perfectly fine. It's pretty self-limiting. That being said, several months later, the conversation has changed a little because 5 months ago, your young adult may not have caught COVID because many people were vaccinating and the risk was low. There were no surges several months ago. That's changed. And now what most of the professionals that I'm listening to and that others are listening to are saying is that at this point, most people are going to catch COVID. So what you're saying, Shoshana, is that once you leave your home or you leave your pod, you're being exposed. I know many people who are positive right now and don't know where they got it, but if you leave your home, you're going to talk to someone and be in an environment with someone who may get you sick. So for those people who are immunocompromised, I guess that's a very good thing to keep in mind.
Yeah.
Thank you. Let's just keep going through the questions here. Why would people choose the antibodies, the monoclonal antibodies, instead of the vaccines? So that, Shoshana, we were just discussing that. That's a good question. Why would someone not get the vaccine but get the monoclonal antibodies? So
I'll put it straight out there. The vaccine prevents illness, and that's step one. Don't get sick. The monoclonal antibodies treats illness. Now with the prophylactic,
right.
Okay, so now with the prophylactic, and it's there and it's available, because if you, not everyone is going to qualify for it. That's number one. Okay, so number one, not everyone's going to qualify it, and for as long as you are not vaccinated, you are a potential vector of spread. Means that you can be the person who's getting somebody else sick, and you can still get sick. Could there eventually be a world where prophylactic antibodies is in every doctor's office and every single person who's ever exposed? Could that be? Yeah, I'm not a doctor, I'm not a scientist. I don't know. You could answer that better than I can probably, but we're not there yet. And until such time as you can definitively go and get monoclonal antibodies, no problem, once a month, because you can still spread it. You can still get it. And viruses are smart, so they can still change and adapt and get us sick all over again.
So I think what's just disconcerting to some people is that no one wants to get a vaccine which they feel is new and is only under emergency use authorization, but they're very comfortable getting monoclonal antibodies, which may be just as new, are still under emergency use authorization. And if you actually read the insert, which many people are very concerned with reading the insert, which is very full of good information, they say, if you actually read the insert, it says that safety studies are still ongoing, efficacy studies are still ongoing. We don't know all the side effects. They literally tell you that. And people who do not want the vaccine because they're so afraid are very comfortable getting the monoclonal antibodies. But my assumption is that they're taking, they'd rather not do something that they may not have ever needed. Like if they feel like they may never catch COVID, then the vaccine is useless for them, right? You know, I'm just not going to catch COVID. Why do I need the vaccine? Once you get sick, you have less of an option. So now you don't want to die. You don't want to get severely sick. You don't want to need oxygen. You don't want to get hospitalized. So it's just unfortunate. I do have a question.
Yeah, but I will interrupt you for just 1 second and say, if you think about the numbers, over 1 billion people globally have gotten vaccinated. We're not anywhere near that number.
Actually, no, 2 billion doses. So yeah, about
right.
Yeah. I mean,
okay, so we're not anywhere near that number with monoclonal antibodies.
No, we're not. No, we're not. And it's just interesting because with such a humongous, this is the largest vaccine initiative ever done in the history of the world, and all eyes are on it. And all of the monitoring programs are being really vigilant. The assumption that things are just slipping by or being ignored by hundreds of thousands of people collectively, it's a conspiracy thought that probably frightens a lot of people, but they really don't need to worry about that because the likelihood of that happening is terribly low. So, okay, there have been stories of women reporting changes in their menstrual cycle. Is this a rumor or is there data supporting this? So, good question. I don't have a great answer, but if I do get more, if I do dig a little more, get a better answer, I will report on it, hopefully next week, or I'll just post it on social media. The anecdotes have been pretty high. Many women who have gotten an mRNA vaccine have said, oh, my cycle was different, or it was delayed, or it was heavier, or I didn't get my period for 2 months. So when many people complain of the exact same thing, then it's a very important thing to look into it. So they have. And just interestingly, just yesterday, I saw a study that came out that evaluated the reports that came in of changes in menstrual cycles compared against the amount of vaccines given, and it was negligible, considering the fact that people's cycles change very easily with any change in their lifestyle, in any medication use, and anything like that. So this study found no correlation. I'll be honest, I don't know that I trust this data because I think there might be a correlation. That doesn't mean it affects your fertility because women's menstrual cycles change all the time. And we know that. Stress, new medications, which a vaccine can certainly just trigger a little bit of a change in you. And what's very important, and I don't think many people realize this, is that your endometrium, which is of course part of your reproductive system, is actually part of your immune system. So it's extremely plausible that getting a vaccine, which causes a really inflammatory and highly responsive and reactogenic immune response, it's just really likely that part of that immune response means a little bit of a change to your menstrual cycle that's temporary. But the only data I've seen so far came out about a day or two ago. I can post that on my social media. So if you want to see that study, please either ask me for it later and remind me, and I'll post it to my Facebook and my Twitter. I'll let you have access to that. Okay. Okay, so someone here is suggesting that monoclonal antibodies only last 90 days. So I'm going to assume that, and please correct me, Shoshana, or I think it's Chaim messaging me here in the group. Please correct me, but I'm assuming if someone gets it prophylactically, they are eligible or should get it again if they're exposed 3 months later. That's the takeaway I'm getting from this message, but feel free to correct me. Okay. I know many people have questions about how long, or rather how not long, it took to develop the vaccine. So that's one of the biggest questions. It was developed in a year. I'm not taking anything that was, oh, 1 second. I'm so sorry. I'm going to go back to this. The FDA suggests that you get the prophylactic monthly. Okay. So I stand corrected. And this is actually really important information for people who are immunocompromised or who are exposed to COVID or who are pregnant. Definitely keep this in mind or call the COVID hotline. Zeldy, can you please remind us what the phone number is so I can just say it for everyone, because I remember 848, but that's all I remember. You can get the monoclonal antibodies as a prophylactic measure once a month. So keep that in mind. But what I was talking, okay, so it's 828, the number 4, and the word plasma, Plasma. So keep that number handy, keep that in mind if you're in a population that may be compromised. So how is the vaccine developed in a year when it usually takes about 10 years? So there are several answers. I'm going to go through them rapidly, and I can also direct you to some good articles on the topic. So number 1, studies on coronaviruses have been going on for decades. So this is not a new virus that needed everything started at the very bottom. It just didn't happen. This has been ongoing, especially since the SARS program that began, the first SARS pandemic that began in 2003. All the scientists at the time were putting their resources together, putting their teams together, doing everything possible, but the pandemic was controlled really tightly. That meant that the funding stopped. So all of their research was shelved. What that means is that last year, they simply pulled all of that research off the shelves because the spigots for funding were wide open. The entire globe was affected, which means every scientist put everything on hold to focus on a vaccine and other protective measures or treatment measures. So this has probably not happened in a very long time, or if ever, where you had a huge collective response where hundreds of thousands of scientists were putting their heads together and all of their independent research together. So first of all, that's a huge step forward, especially using the fact that they were using data that had started in 2003. Number 2, the messenger RNA vaccine method has been studied since the 1990s. There's a Hungarian researcher that actually perfected it. She's been working on it for years, probably never thought it would amount to anything. I think she's being recommended for a Nobel Prize at this point, which is certainly warranted. The only problem with why the messenger RNA was not working was because messenger RNA disintegrates very rapidly. So for those of you who think it's lingering in your bodies and circulating and going into the nucleus and causing DNA changes, it's all absolutely false. There's actually no way it can get into your nucleus of your cells to change your DNA. But on the contrary, the messenger RNA particles were not even staying active long enough to create the proteins to develop antibodies. So that was holding them back. And in the past few years, researchers were working this out and slowly coming up with a structural method to make that work. So, and then at the same time, you have funding for everything, funding and red tape, which was eliminated, no red tape over here, made things easier. And finally, 2 very important points. Number 1, huge amount of volunteers. So people were really, really, really happy to volunteer their time. I tried volunteering, but since I had COVID, I wasn't eligible anymore to be in the trial. They wanted people who had never had COVID to see if the vaccine works. So thousands upon thousands of people who immediately signed on. And the most important part is that it took really fast to see results. Because if you're studying a virus like the measles, for example, it's rare, it's not common right now. So if you want to see if something works against it, you're going to wait a really long time to see if anyone develops the measles, okay? With COVID, when they gave the placebo shots to the placebo group and gave the vaccines to the vaccine group, it took a matter of weeks to see that the vaccine actually works because COVID is so rampant and was so rampant last year when they were trialing it. So for all of these reasons, the SARS research was already there. The mRNA research was already there and being tweaked. It worked all together. It came out well. The studies were well-funded and began rapidly, and the outcomes were really, really, really fast. So that's really how it was developed so quickly. And yes, phase 1 and 2, certain phases were combined to expedite that as well. we're actually over our time. So we do need to end for now. If there are any last minute questions, I can probably take them. Otherwise, we can end now. We'll put this up on YouTube for those of you who missed parts of it or want to share it with anyone. Otherwise, we'll sign off now. Thanks so much to everyone for joining. I hope we've answered some of your questions. And if there's any topic you'd like me to cover, if we do this next week, then please either send me a message or let me know what you feel is important for people to discuss next time.